My talk is entitled Tackling the COVID-19 Pandemic, Year One of a Frontline Provider and National Advisor. I'm an emergency medicine physician and a critical care physician, and this talk's going to be largely a reflection of my experiences over the past year. I'm going to discuss some lessons that I've learned and hopefully provide you with some new information about how we can do better, how we can address issues in the pandemic, and provide some personal experience on that. In terms of conflicts of interest, I served on the Biden-Harris COVID-19 Advisory Board in the fall, and I recently had a grant funding from the National Institutes of Allergy and Infectious Diseases to address COVID-19 vaccine hesitancy. And these are the themes and goals of this talk. I'm going to describe my experiences and the experiences of others over the past 15 months, and I'm going to describe it in 3 phases. I'm going to discuss 3 major issues in terms of research and hopefully describe some action plans to address these particular topics. The first is addressing the effects of the pandemic on the mental health of frontline providers. This was a huge issue, has been a huge issue, and I'm going to talk about that for the beginning of my talk. Next, I will move into talking about helping under-resourced communities that were hit particularly hard during surges, COVID-19 surges, and these communities had a very difficult time with the COVID-19 pandemic, and I'm going to talk a little bit about that, give my perspective on how we can address that issue. And then I'm going to finish with, in terms of phase 3, I'm going to talk about equitable distribution of the COVID-19 vaccine, especially getting into the topic of vaccine hesitancy, which is a major issue across the country. To put the landscape out there, for those of you who are not familiar with emergency departments, but emergency departments are really the front line of care, of critical care, and have been the front line of critical care for the pandemic. At times before the pandemic, the emergency departments can be very chaotic environments. Patients get brought in with very little information. They are often critically ill, and we don't have a lot of data on them. We're not often able, if they're so critically ill that they can't speak, we're not able to get a lot of history from them. And we take all comers 24/7. So at times we can be hit with a big load of patients, and that leads to an inherently chaotic environment. And so along with intensive care units, the EDs and their staff have been disproportionately affected by the COVID-19 pandemic. We really have, in terms of the emergency department and the intensive care unit, we really have had a frontline burden and the honor of serving on the front line for this pandemic. So the first phase of the pandemic was really began in sort of February and extended through May from my perspective. And this was right at the beginning when we were just hearing about reports of cases coming through. There was very little information out there. And at the beginning of the pandemic, we suffered severe shortages of PPE. We had very limited testing. We were unable to get answers right away about whether patients had COVID-19. We had really no direct treatments for COVID-19, for critically ill patients with COVID-19, other than our standard support of mechanical ventilation, oxygen, and other standard critical care treatments, but really had no treatments other than what we typically do to support patients. A lot of emergency departments were faced with overwhelming surges of patients, and we also noted infections and a few deaths, unfortunately, in emergency department personnel across the country. And then lastly, there was this issue of unknown transmissibility. Really did not have a lot of information about how transmissible COVID-19 was, how in terms of day-to-day working in the emergency department and working in the intensive care unit, whether we were going to be get infected with COVID-19. There was just not enough information out there. And all of this really led to deep effects on frontline providers. I distinctly remember being in the emergency department that those first couple of months in March and early April, and that the working environment just transformed. Usually before pre-pandemic, the ED was, worked very hard, but it was very jovial. People would talk a lot all the time. We would share meals in break rooms. It was very, I wouldn't say jovial, but there was a lot of interaction in the staff in the emergency department. In March and April, in the early parts of the pandemic, the emergency department took on a bit of a somber tone. We were affected by all of these factors that I've listed here. It was an acute, dramatic change in sort of our work environment. And so I got together with some investigators, other emergency physicians at other academic centers, and started a couple of studies to look at the effects of the pandemic on the mental health of frontline providers. And I'm going to describe these two studies that we did. The first one, which was we started in April and continued it through the beginning of May. We looked at 426 emergency physicians at 7 emergency departments. Most of them were here in California, but we also included colleagues in New Jersey, Camden, New Jersey, as well as colleagues in New Orleans at LSU. And we basically performed serial kind of surveys with specific instruments to measure a few outcomes in terms of these emergency medicine physicians. We were looking at trying to measure their stress and anxiety that was induced by the COVID-19 pandemic, using some scales to measure that. We're trying to identify what were the particular stressors that they were facing. And then lastly, we wanted to come up with some answers or ways to mitigate against that stress. And hopefully we could provide some answers to institutions as to measures that they could use to mitigate, to hopefully relieve some of that stress that they were undergoing. And so what we found was that there were across the board moderate to severe increases in their stress and anxiety at work. We found substantial increases in emotional exhaustion and burnout, burnout is already a big issue in emergency departments. Emergency medicine physicians and emergency nurses are among the highest risk medical personnel for burnout. And notably also, we found very substantial effects on the home life, on stress in terms of the home life for these physicians. The physicians noted marked changes in their behavior at home. Over 3/4 of them reported that they were less likely to hug and kiss their loved ones. A lot of us, I'd say most of us, would immediately upon getting home, we would jump in the shower, and sometimes we would shower outside, and because we're super concerned about transmitting COVID-19 to exposing our family members to COVID-19. Quite a few of us would stay in hotels and other places away from home during the early parts of the pandemic. And then they also noted that friends and family would treat them differently. They were afraid, some of them were afraid to come in contact. And I noted, and multiple people noted that, whereas in addition to the sort of decreased interactions with friends from the pandemic, there was an increase in people's hesitation to be around you. So this is a scale of the concerns that the emergency medicine physicians expressed. The top of the screen here, I think it's cut off, but not far and away, the number one concern was the availability of personal protection equipment, PPE. That was far and away the greatest concern in the early part of the pandemic. The next major concern was our ability to diagnose COVID-19 cases quickly. Back then, we were limited in the number of COVID-19 tests that we could send from the emergency department. And in some cases, we couldn't send a test. And even when we were able to order the test would come back 2 to 3 days later at times. And that makes it really difficult to manage a patient in an emergency department. When you can't really confirm the diagnosis with a test, it makes it extremely difficult. The other concerns were exposing family members to the virus from their work in the emergency department. There was a lot of concern about coworkers who had been infected with COVID-19, concerns about having to undergo quarantine, and then just a lot of other concerns that were throughout the population as well, like the social isolation factor. All right, so far and away, the biggest concern was PPE. So in terms of mitigation measures, in terms of the recommendations from this first study that we gave, was far and away is we had to make sure that people had adequate PPE, that there was enough supplies, and that people could have faith in their ability to have PPE on the work site. The next measure that we recommended, or that physicians recommended and that we put forth, is to develop more rapid turnaround testing in the emergency department. In other words, we can't wait 3 days for somebody's COVID-19 test to come back. We need it, that day or within hours. We also wanted testing at our discretion. We didn't want to have to go through and ask somebody else whether we were allowed to test a patient for that. We wanted better communication about protocols and also assurance that if we were indeed to get infected and then we had to undergo quarantine, that we would be able to take adequate leave for that. The second study that we started was more of a national study. This was in conjunction with the Centers for Disease Control. And in this study, we looked not only at emergency medicine physicians, but we looked at nursing staff. We looked at social workers in the emergency department, other staff in the emergency department. We sort of took a comprehensive look at people working in the ED. And we looked at a lot of those same measures. And this study was at a later point in time. It started in May and it continued through November. We looked at some of the same outcomes as in the previous study, but we added a few things. We looked at risk for post-traumatic stress disorder from their work in the emergency department during the pandemic. We looked at the mitigation effect of providing testing of workers in the ED, serial testing for COVID-19. And we looked at whether that increased testing of people working in the emergency department would relieve some of their anxiety. And so what we found in this second study was, again, moderate to severe anxiety across the board. Basically, everybody had increased anxiety in the workplace during the pandemic. Notably, there again, this was 20 sites across the country. Some of these sites had very high surges of COVID-19 cases. And notably, the effects on anxiety were about the same in surge sites as in other sites, indicating that it's really a pervasive effect on emergency department personnel. Approximately half of the personnel surveyed and interviewed expressed severe emotional exhaustion and burnout, with female gender having higher levels of being associated with higher levels of emotional exhaustion. We found that approximately 20% of our personnel were at risk for post-traumatic stress disorder, and over half of them had at least one symptom. About 2/3 of them had at least one symptom of post-traumatic stress disorder, such as nightmares, feeling on edge, avoiding triggers, or feeling numb or feeling guilty. And then finally, we did note that serial testing of providers did provide some relief of anxiety to the personnel. By knowing whether they were positive for COVID or knowing whether they had antibodies for COVID, that helped relieve some of their anxiety. So one of our conclusions from this study was that we needed increased testing of personnel in the emergency department. And again, these were the summary of our two studies in terms of mitigation factors, things that institutions could do to help relieve the anxiety and burnout in emergency department personnel. So again, it was PPE, increased testing of patients and of providers. There was a big push for increased consultations for mental health, to promote mental health resilience and assurances that they can take leave. But as everybody knows, the ultimate mitigation measure for COVID-19 is really COVID-19 vaccines. And since we've been vaccinated, most of us received our vaccines in December and January. The anxiety has really declined precipitously. So now I want to move into the second phase of the pandemic and discuss another issue, specifically the issue of poor communities, under-resourced communities, and how they struggle to deal with the pandemic. And this phase, which was from June to about October of last year, for me at least, was characterized by, we started to getting more PPE, so that was becoming less of an issue. We had two new treatments for COVID-19, which were dexamethasone and remdesivir. And we had some more information about how to treat our critically ill patients with COVID-19, in terms of ventilation strategies and things like proning, which basically is putting the patient from lying on their back to lying on their stomach while they're on a ventilator. We had improved diagnostic testing in terms of we would get COVID-19 tests back more rapidly, and there were much more available. But this phase was characterized by catastrophic surges across the country. There were just various communities that were being overwhelmed with COVID-19. We here in the Bay Area never really had that, fortunately, but a number of communities across the country were suffering catastrophic, severe surges of COVID-19. And I'm going to describe my experience with that in this phase. So I'm from Brownsville, Texas, which I don't know if you can see the cursor here, but is the very southern tip of Texas. It's the southernmost point in the continental United States. It's kind of on a parallel with southern Florida. My house is literally a mile from the from Mexico. As a youth, I could walk to Matamoros, Mexico. On July 4th of last year, I received a call from a friend who's a congressman in Brownsville, Texas, and he described a catastrophic situation occurring down there. I had already heard through various people and on the news that South Texas was being overwhelmed with COVID-19. And I know my community down there. Again, I have large extended family down in Brownsville, Texas. My father, who was alive at that time, lived down there. My brother, and I have a lot of cousins and just a huge extended family down in Brownsville, Texas. And he called, so my friend called me to ask if I could come help with in the hospital down there. And they were having a major surge of COVID-19. Another point about Brownsville, it's right on the Gulf Coast. And the day after I arrived, or a couple of days after I arrived, a hurricane hit. And this is the a hurricane tracing. This is the path of the hurricane. I didn't draw this with a Sharpie like somebody else that you may know. And Brownsville is very tropical. You can see the palm trees here. A couple of things, and this is the key point of this part of the talk, is that Brownsville is a very poor community. Its population of Cameron County, Brownsville is the largest city in Cameron County. Population is about 400,000 as compared to San Francisco, which is about 880,000. Close to 90% of Brownsville is of Latinx heritage or ethnicity. And the income, the median income in Brownsville is less than $10,000 as compared to San Francisco, where the median income is about $140,000 per year. Brownsville is the second poorest community in the country. This is downtown Brownsville with the annual Charo Days Festival. This is downtown San Francisco. So I'm going to talk a little bit about how that under-resourced area affects the care during the COVID-19 pandemic. Another important point in terms of Brownsville is that it's pretty far away from another major city. So San Antonio, which is up here, Brownsville's down here again at the bottom of the tip of Texas. San Antonio is about 300 miles away from Brownsville. And in Brownsville, there are, and in Cameron County, there are 4 hospitals. And there's one hospital that has a small residency. And in Brownsville and in Cameron County, there were, at that time in July, there were a total of 6 intensive care unit doctors. This contrasts with the Bay Area and San Francisco, in which there are at least 16 hospitals. There are multiple hospitals that have very robust academic residencies. There's 10 of them at least. And I surveyed various hospitals and came up with that there are at least 200 intensive care unit doctors in San Francisco. And if you count other doctors that can provide critical care support, there's probably closer to 1,000. Other disparities, I got down there in the middle of July. I walked into the hospital. Nobody had really met me. I had obviously talked to them by phone and was put in charge of a COVID-19 intensive care unit there. It was sort of a makeshift ICU that they had put together because the hospital was simply overwhelmed with COVID-19 patients. So at this hospital, which was a 240-bed hospital, there were between 150 and 180 COVID-19 patients. And there were at least 50 to 60 of those COVID-19 patients were critically ill that belonged in intensive care units. There were 2 intensivists. Each of us were operating solo to take care of these 50 to 60 critically ill COVID-19 patients. We had limited consultations in terms of other specialties like neurology, cardiology, and nephrology, all of which are very important contributors to care for COVID-19 patients. And this contrasts to I attended in the intensive care unit of another hospital here in the Bay Area. And when I'm there at that hospital during the pandemic, when I was there during the summer, they would have at most maybe 30 COVID-19 patients in the hospital. There were about at most 3 to 5 critically ill or intensive care unit COVID-19 patients. But I also had a team of residents, fellows, and other doctors that were helping me to care for those limited number of patients. And I also had much more access to consultations from other services. So it was quite a contrast between the situation working in the ICU there from my home base here in the Bay Area. We're running from code to code all day. We had multiple patients die a day. We had young patients who were critically ill, people in their 20s and 30s. It was a very difficult experience. We had, in terms of other resources that were limited at that hospital, we of course had limited ICU beds. They had to make makeshift ICUs on the wards of the hospital, in other areas of the hospital that normally don't serve as intensive care units. We had limited ventilators, so we had to use what are called transport ventilators. These are these small ventilators that are very, very limited in what you can do with them. We had limited medications that we normally use to treat, to sedate and otherwise care for critically ill patients. We had no midazolam, we had no fentanyl, we had no vecuronium or cisatracurium, so we had to substitute other medicines that are more difficult to use in those circumstances. We did not have any dexamethasone, which was the drug that had been shown to improve outcomes in COVID-19 patients. So we substituted another agent. We had limited remdesivir, and we had no ECMO. In other words, we had no basically life support where you put a patient on full life support with cardiac bypass. And these disparities led to greater COVID-19 mortality. So Brownsville and Cameron County at the time had fourfold the case fatality rate that we had here in the Bay Area. At that time in August of last year, in Cameron County, which is half the population of San Francisco, there were 629 deaths as compared to 72 deaths in San Francisco, which has twice the population. One thing that I want to make clear is that it's not these communities' fault. The communities, the people there were being very responsible. They were always wearing face masks. They weren't out throwing wild COVID-19 parties. They respected healthcare workers and the advice of healthcare workers. This is a picture of when I would come out of the hospital in the evenings, late evenings. There would be groups of people singing hymns and trying to uplift the healthcare personnel there. It was very moving. I lost 2 friends to COVID when I was down there. This is my friend Joe. He taught me how to fish and how to drink beer. So I left Brownsville with very mixed emotions. I was relieved. It was one of probably the most difficult work experience of my career. I was relieved to get back to the Bay Area, to my normal work environment. But I felt guilty because I knew that there was a severe shortage of doctors there to help, and that help was not in sight. It was at least a few weeks away that other doctors were going to be able to come out. So I wrote this article, and I made some proposals about how to deal with this issue of under-resourced communities and their lack of access to medical care and to specifically to deal with surge capacity. And this article basically describes that there's basically a 3-week window in which you can address major surge need. So when communities start, this was again back in the summer and fall, you would note an increase in positive tests in the community. And then from that point on, you have about a 3-week window to get help, to get them help in terms of critical care surge support. About 2 weeks after they start having community testing, increased prevalence, you're going to see patients admitted to the hospital. And then about a week after that is when they're going to start showing up in the intensive care unit. The current FEMA system was not designed at all to deal with the COVID-19 pandemic. It was really designed to deal with regional disasters like hurricanes, earthquakes, and things like that, just localized to one region. The FEMA system consisting of like military support, it plods too slowly. It just can't get to all these hotspots. What is needed is a system that's regional and nimble. And so I proposed this, and I proposed this nationally as well, is developing teams of strike forces of physicians, nurses, and respiratory therapists that can quickly mobilize across the country to help these under-resourced hotspots. You would have to begin by identifying these communities in advance and looking at on a map. And this is a map of, right here is a map of poor communities in the country. And Brownsville here is, in blue, of course, being one of the poorer regions of the country. And so you have to plot those regions on a map. You have to start screening those areas for increased COVID-19 testing prevalence, and then develop supply bundles and develop these registries of strike forces of, again, physicians, nurses, and respiratory therapists that can mobilize during that 3-week window. Another thing to consider is that you have to develop a credentialing system for waivers such that a doctor from California can easily go to Texas and help out. All right, so I want to get to the phase 3 of my year in the pandemic. And this is the phase of hope. And that started for me, I would say, in about November, and it's continued through now. The November election brought new leadership, and I'm trying not to get overly political here, but the new leadership took the pandemic seriously. I received a call 2 days after the election by members of the Biden-Harris team, and was asked to serve on their COVID-19 advisory board, alongside with a number of outstanding physicians, including the current Surgeon General, Atul Gawande, and a number of other remarkable people. And from our first meetings with the administration, with the president and those teams, it was clear that they that this was the number one priority, that they were going to start taking it seriously, and and really try and turn this around. So since November, and over the past months, we have better testing. We've also, in terms of medications, we have some new antibiotic therapies and other treatment regimens. We have a much more organized response to deal with surges and with other issues. And very importantly, obviously, most importantly, vaccine distribution has been accomplished very, very well. But however, we're not out of the woods. There are a number of remaining issues. And this is going to be the last part of my talk, which is I'm going to talk about barriers to COVID-19 vaccination. As mentioned, the supply is better now, at least in the US. Delivery and administration is much, much better. You can get a vaccine just about any place in the country now, but we're still dealing with this problem of vaccine hesitancy. Again, my last topic is how to deal with the issue of vaccine hesitancy, and specifically how we can address it through the emergency department. So the emergency department is the safety net of the safety net. It's where vulnerable populations go. It's often the only healthcare access site for a lot of people. Their only place to go is the emergency department. And this includes homeless persons, immigrants, uninsured. It really is, the bottom line is the emergency department is the ultimate safety net. And notably, African Americans and Latinos get a disproportionate amount of care in emergency departments. And these groups have suffered at least 2 times the morbidity and mortality during the COVID-19 pandemic. So this leads to kind of the principle that in order to help these vulnerable populations who don't have access to healthcare, who can't just go online, a lot of people don't have internet access, they can't go online and schedule an appointment for a COVID-19 vaccine. You've got to go where they go. And so you have to deliver interventions in the emergency department and develop ED, emergency department-based COVID-19 vaccination programs. So we did this study in 15 emergency departments across the country. We looked at 2,300 emergency department patients, and we asked them about their vaccine healthcare access, their hesitancy to get the COVID vaccine, and also questions about their mask wearing practice. And what we found was that 20% of respondents in this survey study, their only healthcare access is in emergency departments. And most of these, 2/3 of these were African-American and Latino. 2 big points about this was that 44%, a much higher percent of these patients were vaccine hesitant. They were afraid to get the vaccine. But those who would accept the vaccine, the vast majority of them, 94% of them, said they would accept it in the emergency department as part of their care. And this is a graph of the individual sites and their COVID-19 vaccine hesitancy. It did vary across the sites, from the lowest being at Parnassus Hospital. San Francisco General was right in the middle. And then the highest rate of vaccine hesitancy was in Camden, New Jersey. And the reasons that they were hesitant to get the vaccine was their concerns about side effects. They didn't believe vaccines would work. They didn't want to be the first to get a vaccine, distrust of healthcare systems. And then in the immigrant population, there's this fear about providing too much information and whether that information would be shared with ICE or other organizations. So my final points are that we should consider addressing vaccine hesitancy and barriers to vaccination, to COVID-19 vaccination in the emergency department. We need to be, as emergency physicians, trusted messengers for these patients. We should try to provide the vaccine in the emergency department, but if we can't, we should tell them where they can get it and even set up appointments if we can, if that's available. We should assure immigrants that they are safe from discovery and deportation before getting a vaccine. So my last slide is about summer and moving on. As mentioned, I do have a grant to address vaccine hesitancy through the emergency department. I'm working with a team of multiple other individuals. We're looking to try and develop a COVID-19 pandemic commission. And I think we need to really push to treat COVID-19 as more of a global issue. These are hotspots across the world, and many countries are where we are last summer now and are undergoing severe surges. And so we really have to support those other countries with vaccination. And this is my last slide. And thanks.
Well, thank you so much, Rob. That was really moving, and I knew it would be, and it was really terrific. So thank you so much for doing it.
Thank you.
And thank you for all the work you've done. It was really quite remarkable. I have a couple of questions. The first one came in from the audience. The first study you showed, or maybe it was the second, about the experience of physicians, clinicians, I guess it was the second one, clinicians in the emergency department had the gender differences. And I wonder if you had any hypotheses as to why that was the case.
Yeah, that's a great question. We looked into that a little bit further, and it's thought to be because of increased responsibilities at home, perhaps the dual, the greater caregiving responsibilities that women typically have. That was one of the reasons that was thought for that to occur, and that gender difference has been reproduced in other people looking at that same subject, but it is a complicated issue.
In an analogous line, I know your study focused on emergency physicians, but did you pick up any signals about other specialties, and not necessarily the ones who you would expect? You would think, I mean, one thing about emergency physicians is that it's the most stressful of our clinical environments in most respects. And so in some ways, resilience may be particularly high, yet you saw so much stress. Did you see similar stress in other high stress clinical environments? And also, did you look at lower stress environments in which people still might have experienced anxiety?
Yeah, that's another great question. So we did actually look at a smaller sample of physicians in other specialties. We looked at, here at UCSF, we looked at physicians in let's say, family medicine, in obstetrics, and some of the surgical specialties. And they also noted increased stress during that early part of the phase of the pandemic. So it really is we don't think that it's unique to emergency medicine. It really was a pervasive kind of feeling across healthcare environments. And a lot of it had to do, again, with unknowns during the early part of the pandemic and limited availability of PPE. And we also, of note, in one of the studies, we looked at people who did not have direct patient contact, people who were like clerks and things like that in the emergency department, and they noted similar stress. So it's a pervasive phenomenon, and I think that, again, now that people are vaccinated, it's been a great relief.
In that context, not so much the vaccine context, but the stress context, by the time you got to Brownsville, I mean, and you implied this, I mean, it sounds like you were experiencing what people are experiencing still around many parts of the planet. And what happened to your own anxiety? I mean, it already must have been really high. Did it go higher, or did you just sort of go through some stages of acceptance, or how did you experience being there when you were so isolated and alone?
To be honest, I was overwhelmed. It was a deeply personal experience for me. I had friends, again, that I had lost there. I was born in that hospital. And it was a very, wanted to stay at my dad's house, which was less than a mile from the hospital, but I didn't want to expose him. And so like it was my anxiety, in short, my anxiety escalated quite a bit. And it was a very difficult experience for me. I didn't, not trying to be melodramatic, but it was just on a personal level and a work level, just many times over an extremely difficult, anxiety-provoking experience.
I'm sorry, just even hearing it is moving, and I'm sorry you went through that, but you accomplished so much on behalf of so many, so thank you for that. Let's move to something less moving. One question about PPE. There were, we all remember that those first early phases when PPE was the topic of conversation. Is the questioner asks, are there any ways to estimate how many excess deaths there were related to poor use or poor supply of PPE? And secondly is, where do we stand now in terms of supply chains and the way we're managing PPE? And I guess you could add a third part, which is what's happening around the rest of the globe around PPE issues.
Yeah, I can answer the U.S. supply chain question first, and we are now well stocked in terms of PPE. It's no longer an issue, and in fact, there may be, we are probably able to stockpile some PPE. In terms of globally, on the other hand, it's still a problem in poorer countries. It's not just like the vaccine and other issues. It remains an issue. In terms of, with regard to how many excess deaths resulted from that, I don't know that we'll ever get an answer to that. I think that there certainly were some, and we are actually in the final stages of another study looking at our exposure as emergency physicians, excess exposure, and we will have the results of that within the next month. So there are particular, we will be able to report on excess exposures, cases, and even deaths, but whether we can attribute those to lack of PPE or not, it's complicated. So I'm not sure we will ever get an answer to that.
There's a question of the day that has come up, not so much in our region, but elsewhere around the country, many other places around the country, about incentives for vaccines and then restrictions placed on people who don't get vaccines. So sort of both sides of that related to incentives and lotteries, and also vaccine passports, and especially the racial and ethnic aspects of passports in particular.
Yeah, so the incentives, I think, I'm fine with those. I think it's good to be creative, and anything that we can do to get people to accept the vaccine, I'm okay with. It's a little, I don't know, I don't know if disheartening is the right word, but it's a little bit disappointing, I guess, that we have to do that when, and there are other people in other countries that are just begging to get a chance to get the vaccine. I don't know. I mean, but I think I'm okay with all of the sort of incentives to get the vaccine. In terms of the passports, that's a tricky issue. You know, I think that for certain, like, let's say air travel or things like that, I think companies should be allowed to make a requirement. I think, but I don't know. In terms of like other, like, I don't think that it should be carried to an excess in terms of like limiting whether somebody can go to a national park or something like that. I don't know. That's a very tricky issue, and I think that yeah, that it should be. It sort of depends on what you're wanting the passport for.
Well, especially if there are structural issues like racial and ethnic class issues that determine who has more hesitancy, say. And then if you're then discriminating against people with more hesitancy, it's sort of a double whammy. I mean, certainly some employers, including our own, is mandating that people get vaccines. And so it is going to be a tricky thing. I mean, I wonder, what are your views in terms of the Latino community? I mean, what are your thoughts?
Yeah, I think that we need to use culturally appropriate messaging for various communities. I've been a part of some PSAs for Unidos US, which is a very strong organization for Latinos. The grant that I received recently, we are going to be looking at Spanish speakers specifically and how to address vaccine hesitancy in those groups. And we're going to be looking at, you know, all vulnerable populations. The proposal is at 4 sites. We're the lead site here in San Francisco, but it's also going to be in Philadelphia, in Seattle, and in North Carolina. And so we're going to take a serious look at what messaging works best and whether we can sort of provide that messaging and perhaps provide vaccines through the emergency department, which is an underused sort of public health messaging center, a place to provide messaging.
Where does it stand now in terms? I assume you're giving mostly Johnson and Johnson, and what is the current state at say at Zuckerberg and at Parnassus, and then sort of a subset of that is I've been arguing that it should also be in physicians' offices. So I've had a number of patients where, you know, I'm trying to, you know, make the pitch, and if I had it right there, and the nurse was there with me, you know, we're getting ready to go, I might have had a better shot than making an appointment. We're beginning to see it moving into pediatric offices, which is great, I think. Just wonder your thoughts on both of those.
Yeah, so the J&J vaccine certainly has is certainly optimal for emergency departments. You know, it's a one-time shot. It would relieve the problem of having to schedule a second appointment. You can give the vaccine while they're there for other reasons is the central premise behind that thought. There was a pause on that and on the J&J vaccine. So, you know, ED-based vaccinations took a little bit of a hit with that. Now at the general And I believe at Parnassus, I'm not quite sure what the practice is at Parnassus, but at the general, now that there's a roving vaccine program. In other words, if you have a patient in one of the clinics, or if you have them in the emergency department, and you want them to get vaccinated, or they'll accept the vaccine, you can call this number, and they will come down and give them the I believe it's still the Pfizer vaccine. Yeah, so that's a great program. I think it can get at all sites, and they can also keep the records better than in a more systematic way. So I think again, like as you said, moving into getting people vaccinated in offices is the way to go, and just really anywhere
Right.
is the way to go. They I saw that our vaccination program at the Moscone Center and the programs run here in San Francisco have been an outstanding success. Kudos to all of those people involved. A lot of them are in my department, including Mary Mercer and Andrea Tenner, Dr. Andrea Tenner. And so it's, that's been a great program. I think that, yeah.
Couple of last questions. Let's see. We heard a lot about institutions, quote, calling in the military. I don't know. Was that part of what happened in Texas, and sort of implying, and where did the troops come from? Is that the FEMA that you're talking about, or was it troops or volunteers like yourself? And what happened in Brownsville after your experience there?
Yeah, so the FEMA is typically military doctors that are and nurses, and what they do is they will send a group to different locations. The problem with that is that it's too slow. By the time they showed up about a month later, basically, at least 3 weeks later after I left. And, the surge had already passed its peak, such that a lot of people, there was no place to care for these patients. So they do come. The problem is that there were too many sites across the country, too many surge sites across the country, and a limited number of military groups, and it's just the system again is too slow. It's not nimble enough to deal with the sites popping up all over the country, and popping up rather quickly. So yeah, I think that we need something in addition to that, and there's been a fair amount of response to that, and yeah, I think that idea is gaining traction.
In that context, was there just your own thinking? I won't put you on the spot politically, but did you encounter, as people in the Biden administration were struggling with what was going on around the country and developing systems, was there talk about healthcare reform in that context, in terms of whether it was Medicaid expansion or Medicare expansion or some other payer changes? What have we learned enough from this to do something like that?
I could say that they definitely listened, and there are definite plans to address those issues. A huge improvement or a huge point of the Biden-Harris initial response and continued response is addressing disparities and addressing healthcare disparities across the country. And so in fact, that is what I would say their number one priority beyond and in conjunction with the pandemic. So I can attest to the fact that they're listening and that those issues are being addressed.
Maybe one last philosophic question, sort of crystal ball question. Given how good things have been here in the last couple of months, here being the United States, say, and how challenging they are in India and Brazil and still other parts of the world, what's your prediction in terms of are the systems that you're talking about for here relevant and implementable through the WHO or internationally, things like that?
I think that it's problematic. I think what is working here is not going to necessarily work in India or Brazil from a systems standpoint. What I do think would work and what is necessary is just vaccinations, just vaccinating everybody across the globe. That's really the only, our systems are so different. Our medical healthcare systems are so different. We, as you know, are very privileged here in the United States in terms of, we can get patients now, just about any patient that needs an ICU can get an ICU bed now. And that's been the case for most of the pandemic, other than, those surge times. Other countries, they can't get that level of intensive care. So you really have to hit it at the source. You have to get everybody vaccinated. And so if I were to invest anything from the WHO standpoint, and if I were in charge of like distributing funds from the US and other countries, I would push just getting more vaccine.
All right. Well, I think that's probably a great note to end on. We are going to talk from various angles about vaccines a lot more next week and the week after for those listening in. But I think the personal nature of the presentation tonight, in combination with the evidence and the policy, was really quite moving and remarkable. And I really want to thank you, Rob. When we named this course, we were thinking scientifically, but we really should have focused more on the heroism, because it really, the work that you've done and some of our other speakers over the last few weeks has really just been remarkable to hear. And I know everyone in the audience will join me in thanking you very much. If we were live, you get a rousing round of applause and appreciation. And on behalf of all of us, thank you so much for everything you've been doing and continue to do. And it's great to have you a member of the UCSF community. And I really appreciate you doing this tonight.
I loved it. It's always great to see you, Bobby, and I totally appreciate the chance to talk about this. Thank you.
Thanks so much. Stay safe and be well.